Physiology of the aqueous humor. The aqueous humor is a clear, colorless fluid that fills the anterior chamber of the eye as well as the area behind the crystalline lens, which is the posterior chamber. The properties of this fluid are as follows. In volume, it's almost 0.3 ml. Its refractive index is 1.333. Its pH is 7.2. That means it's alkaline. And it is hyperosmotic in nature, and its rate of formation is 1.5 to 4.5 microliters per minute. It's almost totally composed of water with some solutes. That is, the water composes 99.9% of it. The proteins are less than 1% the concentration in plasma. Glucose is 75% of that of the plasma. Electrolytes are the sodium, which is equal to its concentration in plasma. Bicarbonates are higher in concentration in the posterior chamber than in the anterior chamber. The chloride is more than in plasma. Phosphates are less. Ascorbic acid has a very high concentration here, and it probably contains coagulation and anticoagulation factors. It serves the following functions. It gives oxygen and nutrients to the lens and partially to the cornea and the iris. It removes the metabolic byproducts of these structures. It provides an optically clear medium of the media of the eye through which light passes. It inflates the globe, maintaining its intraocular pressure, and its high ascorbate content has two functions. First is protection against ultraviolet irradiation, and second is induction of oxidative products like free radicals that protect against harm. It has cellular and humoral responses as well. Now, the blood-aqueous barrier is the barrier between the blood circulation and the space containing the aqueous. So for products to pass from plasma to aqueous humor, they have to pass through this barrier, and the barrier is in the ciliary body as is composed of the avascular endothelium, stroma of the vessels, the basement membrane, and the pigmented and the non-pigmented epithelium. Now it is responsible for differences in chemical composition between the plasma and the aqueous, and the breakdown of blood-aqueous barrier may in some situations be beneficial, that is therapeutic effect, where the drugs can pass, and in other situations it might lead to complications like in conditions like uveitis and trauma. And this table here shows the stimuli that may break the blood-aqueous barrier, and these are namely traumatic, pathophysiologic, or pharmacologic. The traumatic factors might be mechanical, physical, or chemical. The pathophysiologic include vasodilatation by drugs like histamine or due to sympathectomy, infections of the outside of the eye, surface infections, intraocular inflammation, prostaglandins, and anterior segment ischemia. Pharmacologically, this barrier might be broken by the melanocyte stimulating hormone, nitrogen mustard, cholinergic drugs, especially cholinesterase inhibitors, and or plasma hyperosmolarity. Describe the dynamics of aqueous humor, that is, the circulation of the aqueous humor is secreted by the ciliary epithelium that lines the ciliary processes. It enters into the posterior chamber, flows around the lens and through the pupil into the anterior chamber, and there are convection currents of aqueous occurring all the time in the anterior chamber due to temperature gradient. And it leaves the eye by two pathways at the angle. The first is through the trabecular meshwork, then the inner wall of the Schlemm's canal into its lumen, and then into the collector channels, aqueous veins, and the episcleral venous circulation. This is called the trabecular route. The second is across the iris root, then the uveal meshwork, anterior face of the ciliary muscle, through the connective tissue between the muscle bundles, then into the suprachoroidal space and out through the sclera. This is called the uveoscleral or the unconventional route. Here is the structure of the anatomy. I'm sure you're all quite familiar with. This is the iris and this is the angle where the trabecular meshwork occurs. This here is the conventional pathway and this is the non-conventional pathway. The aqueous is produced from the pars peccata along the crests of the ciliary processes, is derived from the plasma within the capillary network of the ciliary processes, and there are three physiologic processes that contribute to the formation and chemical composition of the aqueous humor, and these are diffusion, ultrafiltration, and active secretion, and we are going to describe each separately now. Diffusion is the movement of a substance across a membrane along a concentration gradient. And as the aqueous passes from the posterior chamber to the Schlemm's canal, it is in contact with the ciliary body, iris, lens, vitreous, cornea, and trabecular meshwork, and there is diffusional exchange so that the AC aqueous humor resembles plasma. By ultrafiltration is meant the process through which the solution crosses a semi-permeable membrane under pressure gradient. And as the blood passes through the capillaries of the ciliary processes, about 4% of its plasma filters into the aqueous. In the ciliary body, the fluid movement is favored by hydrostatic pressure difference in between the capillary pressure and the interstitial fluid pressure, while this movement is resisted by the pressure difference in between the oncotic pressure of the plasma and the aqueous humor. The third process is active transport, which is energy dependent process selectively moving a substance against its electromechanical gradient across a cell membrane. It is postulated that the majority of aqueous humor formation depends on active transport, and this goes through the non-pigment epithelial cells. During and through this process of formation of the aqueous, there is a basic physiologic process of accumulation of a plasma reservoir. Most of the plasma substances accumulate behind the tight junctions of the non-pigmented epithelium, and this occurs primarily via diffusion and ultrafiltration. The transport across the blood-aqueous barrier is a selective transcellular movement of certain cations and anions and other substances across a blood-aqueous barrier formed by the tight junctions between the non-pigmented epithelium, and the aqueous humor secretion is mediated by transferring sodium chloride from the ciliary body stroma to the posterior chamber with water passively following. The carbonic anhydrase enzyme mediates the transport of bicarbonates across the ciliary epithelium through a rapid interconversion between the bicarbonates and the carbon dioxide. Other transported substances include ascorbic acid, which is secreted against a large concentration gradient by sodium-dependent ascorbates transporter 2. Biochemically, aqueous formation is aided by two enzymes in the non-pigmented epithelium of the ciliary body. These are the sodium-potassium ATPase and the carbonic anhydrase. The second half of the whole process is aqueous humor outflow, and there is a conventional or trabecular outflow, as we described before, that accounts for 70 to 95% of aqueous outflow out of the eye. This occurs, as we said, through the angle, via the trabecular meshwork, then the Schlemm's canal, the interscleral channels, the episcleral, and the conjunctival veins finally. And the second route is the unconventional or uveal scleral outflow that accounts for 5% to 30% of aqueous drainage. It occurs via the root of the iris, then the aqueous passes between the ciliary muscle bundles, then through the suprachoroidal and scleral tissues. And this here is showing again the two pathways, one through the Schlemm's canal and the second is through the root of the iris. And as you know from your anatomy course, the scleral sulcus is converted into a circular channel, that is the Schlemm's canal, by the trabecular meshwork, and therefore the trabecular meshwork in this area can be divided into three portions: the uveal, the corneoscleral, and the juxtacanalicular tissue. The uveal meshwork is the innermost portion adjacent to the aqueous humor in the AC and is arranged in a rope-like trabecular pattern. The corneoscleral meshwork extends from the scleral spur to the wall of the scleral sulcus, and the juxtacanalicular tissue is three-layered: inner trabecular endothelial layer that continues with the endothelium of corneoscleral meshwork, the central connective tissue layer, and the outermost portion is the inner wall endothelium of the Schlemm's canal. And this figure here shows these three structures of the trabecular meshwork. Lowermost in the figure is the anterior chamber, and then the uveal meshwork, followed by the corneoscleral meshwork, and finally the juxtacanalicular part, which is formed by the cribriform meshwork and then the inner endothelial wall and of the Schlemm's canal, and then the Schlemm's canal. This is a three-dimensional diagram of the area of the angle of the anterior chamber, which is formed of the uveal meshwork, as we said, and the corneoscleral meshwork, and finally the juxtacanalicular meshwork that are inner to the Schlemm's canal that connects to the collector channel and the intrascleral veins. Schlemm's canal is connected to the episcleral and conjunctival veins by a complex system of intrascleral channel. There are two systems of intrascleral channels that have been described. The first is the direct system of large caliber vessels with short intrascleral course that drain into the episcleral venous system, and an indirect system of more numerous fine channels which form an intrascleral plexus before draining into the episcleral and venous system. This diagram here on the left side shows the direct system, and on the right side is the indirect system. In addition to this, there is a pumping model of trabecular outflow, and the aqueous outflow is pumped. It is receiving a sort of a power from a transient increase in the intraocular pressure via three main mechanisms. The first is the systole of the cardiac cycle, increasing the pressure inside the vessels, wherefrom the aqueous is derived. The second is the frequent physiologic blinking, and the third is the eye movement. So, drainage of aqueous is postulated to occur in these 6 steps depicted in this diagram. The diagram shows the cells of the trabecular meshwork with the two sides. One side is the aqueous humor in the aqueous plexus, and the other side is the patterned side where aqueous humor is in the trabecular meshwork. There occur vacuoles, giant vacuoles of aqueous inside the cells. These vacuoles then accumulate under hydrostatic pressure, and then these start to pass into the aqueous plexus, and after that there is fusion of the basal and apical cell plasma lemma, creating a temporary transcellular channel, allowing bulk flow of aqueous into the Schlemm's canal. Now we come to another issue, which is factors exerting influence on the intraocular pressure, and we shall start with the long-term factors, which are namely genetics, age, gender, refractive error, and ethnicity. Genetically, the intraocular pressure is under hereditary influence. It's higher in individuals with enlarged cup disc ratio or those who have relatives with open-angle glaucoma. Age affects drainage of intraocular aqueous, that is, affects intraocular pressure, and it's known that intraocular pressure increases with age, and children in general have a lower pressure. Intraocular pressure is equal between the two sexes in ages 20 to 40, but in older age groups, the apparent increase in mean intraocular pressure with age is more pronounced in women. There is a positive correlation between intraocular pressure and both axial length of the globe and increasing the degrees of myopia. Myopes also have a higher incidence of primary open-angle glaucoma. Blacks have a higher pressure in general than whites. Then we come to the factors that exert a short-term influence on the intraocular pressure, and these are the diurnal variations, the postural variation, exertional influence, mobility of the lids in the eye, intraocular conditions, systemic conditions, environmental conditions, general anesthesia, as well as foods and drugs. Diurnally speaking, the intraocular pressure shows a cyclic fluctuation through the day that ranges from approximately 3 millimeters of mercury up to 6 millimeters. The higher intraocular pressure is associated with greater fluctuation, and a diurnal fluctuation of greater than 10 millimeters of mercury is suggestive of glaucoma, and the peak intraocular pressure is in the morning hours. Intraocular pressure increases when changing from the sitting to the supine position, with an average pressure difference of 0.3 to 6 millimeters mercury. It is greater in eyes with glaucoma and persists even after successful surgery for glaucoma. Patients with systemic hypertension, that is arterial hypertension, have greater intraocular pressure increase after 15 minutes in the supine position. Exertional influence varies depending on the nature of the activity. Prolonged exercise, such as running, cycling, and so on, has been reported to lower the intraocular pressure. The magnitude of this pressure change is greater in glaucoma patients than in normal individuals. Also, straining with Valsalva's practicing electroshock therapy may elevate the intraocular pressure. This may be due to elevated episcleral venous pressure and increased orbicularis tone, increasing the resistance to drainage. Blinking has been shown to raise the intraocular pressure up to 10 millimeters mercury, while hard lid squeezing may raise it as high as 90 millimeters mercury, of course, for a very brief moment. Contraction of extraocular muscles also influences the intraocular pressure, and there occurs an increase in the intraocular pressure on upgaze in normal individuals, which is augmented by Graves' infiltrative ophthalmopathy. Elevated intraocular pressure is associated with glaucoma, and this is a well-known fact. Intraocular pressure may be reduced in anterior uveitis and in rhegmatogenous retinal detachment. There are some systemic conditions that may be associated with changes in the intraocular pressure, like a correlation with the systemic arterial hypertension, systemic hyperthermia, that may increase the intraocular pressure. Some hormones like ACTH, growth hormone, progesterone, estrogen, chorionic gonadotrophin, and relaxin have been reported to affect the intraocular pressure. Intraocular pressure is significantly reduced during pregnancy, probably due to the excess progesterone. It is lower in hyperthyroidism. In myotonic dystrophy, the intraocular pressure becomes very low. Diabetic patients are known to have a higher pressure in general. Patients with AIDS have lower than normal mean intraocular pressure. Finally, there are some environmental conditions that may affect the intraocular pressure, like exposure to cold and air currents. And this is probably because of episcleral venous pressure reduction. Reducing gravity may cause a sudden marked increase in intraocular pressure. And under general anesthesia, the intraocular pressure is reduced, and exceptions to these are ketamine, that elevates the intraocular pressure. Hypnotics reduce intraocular pressure. Tracheal intubation may cause a rise, and elevated PCO2, partial pressure of carbon dioxide, increases the intraocular pressure, while increased partial pressure of oxygen is associated with an intraocular pressure reduction. Some foods and drugs have been reported to have an effect as well. Alcohol lowers intraocular pressure, caffeine raises it, fat-free diet reduces intraocular pressure, smoking increases it. Heroin and marijuana lower the intraocular pressure, while LSD causes elevation of intraocular pressure. Thank you very much.